Okay, this is my last recording for this week, and it is also going to be relatively brief. It is management of the older adult patient. Remember, older adults are the focus of this semester, and part of what you will need to be able to identify is characteristics that differentiate that older adult population from a younger group in the population. So we know that Americans are aging and that the baby boomer generation is very large, and their life expectancy until COVID has gone up a lot in the past 100 years. Why? Well, we've had a lot of advances in medication. So we didn't even have antibiotics in 1900. So the average life expectancy in 1900 was 47 years of age. I have outlived that by 8 years already. But as of 2009, it was 78.8 years. And it went down in 2016 a bit. I can't tell you what it is now. I know it went down a little bit more after COVID. But still, overall life expectancy is pretty high. And that's due to being able to medically manage complex comorbidities. The leading causes of death in our older adult population include heart disease, cancer, unintentional injuries, which I want you to put equals falls, because that is pretty much what happens. I forget the statistic, but basically after the age of 75, if someone falls and breaks a hip, they are so much more likely to die within that year. And if you think about someone who has fallen and broken their hip, they may or may not have gotten it repaired. Let's say they did. Now they've gone to rehab and they're weaker than they used to be. They already fell and broke their hips, so they probably weren't awesome on their ambulation before they broke their hip. Now they have fallen and broken their hip, so they're even less likely to be able to get up and walk around, less likely to be able to take care of themselves, less likely to be eating well, more likely to get pressure injuries and have incontinence episodes because they're unable to get up and go to the bathroom. So many things that can happen because of a fall. Chronic lower pulmonary diseases, so think COPD or pneumonia, strokes, and then it says Alzheimer's disease, but I want to say I think they are lumping all dementias into Alzheimer's disease, and so I don't necessarily want to say it's all Alzheimer's. Our focus is to offer encouragement, support services, and promote health behaviors so that we can help our older population live a quality, healthy life for as long as they can. However, over time and as people age, they are going to have cardiovascular changes. Remember, heart disease is the leading cause of death. They have decreased cardiac output, increased fibrosis, or, like they don't have compliance, so they have reduced stroke volume, increased calcium and fat deposits, which leads to hypertension and increased workload on the heart. And it takes the heart longer to recover after stress. So if you have somebody, walk around the hospital floor and their heart rate goes up to 105 just from that little effort, it may take their heart longer to come down from that exercise than it would a normal, healthy, younger adult. They also can experience orthostatic hypotension, which is changes or fluctuations in blood pressure when changing positions. So when going from lying down to sitting to standing, they will experience an alteration of about 20 points on average, usually systolic, but it can be a 10-point dip in the diastolic number that causes dizziness, basically, because the body's not acclimating or recognizing or registering those changes in position. So that is why sometimes our older population, the member will get up out of bed to walk to the restroom first thing in the morning and they fall and break their hip, probably have orthostatic hypotension. So how do we tell them not to experience a fall? We ask them to change positions slowly. So when you first get up in the morning, sit on the edge of the bed for a few minutes. And when you stand there for a moment. Make sure you're not dizzy, and then walk to the bathroom. Respiratory system changes. Those happen over time. You know, you have reduced compliance in the lungs, reduced elasticity in the lungs. Lung mass decreases, residual volume increases, and smoking obviously is a huge risk factor for degeneration in the lungs. Skin, we've talked about that several times, about how skin changes in appearance. It becomes thinner, collagen becomes stiffer, elastin is reduced, so you get wrinkles. Sub-Q fat diminishes, so you're not going to conserve body heat because you don't have that layer of sub-Q tissue. So that also is part of why you have more risk for pressure injury, because the bony prominences do not have that layer of sub-Q fat. Wrinkling and sagging, hair pigmentation changes, balding can occur, and, gray or white hair. Reproductive system, you have erectile dysfunction. Some medications for blood pressure and others can affect erectile function, leading to dysfunction. And with females, as they age, they have decreased elasticity and vaginal secretions and decreased tone. Males, less firm testes, but they actually can continue to have sperm that's viable for up to 90 years of age. So that's an interesting prospect. Can you imagine finding out you're going to be a dad at 88 or something? No, thank you. Okay, so this would be the urinary system. We have a decreased filtration rate in the kidneys. Kidneys are not as good at reabsorbing and concentrating the urine. We're not as good at restoring our acid-base balance in response to stress. Males end up with BPH, or benign prostatic hyperplasia, which that means the prostate is enlarged. That's all it means. But what that does for your males is it leads to increased nocturia. It could mean they have difficulty starting their stream of urine. So they wake up and they have to pee so bad, and they get into the bathroom and then they just stand there waiting. That's usually due to BPH, and there's medications for that. Sometimes it'll get so bad that they're unable to urinate and they have to have a catheter. So at that point, you're consulting urology and looking at potentially doing a surgery. Females can have, most of them do have relaxed perineal muscles, which is, again, where we were talking the other day about doing those pelvic floor muscle exercises. That helps to delay that. And so when they have this reduced instability in those muscles or those sphincter muscles, then we can have your urge incontinence and stress incontinence, which are both treatable with, as long as we know and we're assessing for it. Now we have the GI system. We have a decreased sense of thirst, smell, and taste. Decreased salivation, which can be simply from age, or it can be from medications. A lot of medications are drying. They may have difficulty chewing or swallowing food, delayed stomach or esophageal emptying, which can lead to GERD, which is gastroesophageal reflux disease. Oh, there it is. Actually, that's diminished secretion of acid and pepsin and reduced gastrointestinal motility. All of those things can lead to GERD, which, even though you may not have as much acid, it could back up into the esophagus and then back up into the throat and even into the mouth. Gross, but true. Nutritional health. We don't need as many calories as we age because we're not as active, but we may need more nutrient-rich foods like protein so that we can continue to keep up our body mass. And it really just depends on what our other comorbidities are, because if we have kidney disease, we're probably limiting protein, but otherwise we might want to increase our protein. Reducing fat intake, C, consuming sufficient protein, vitamins, minerals, and dietary fiber. One of the things for our older population is they may not have the money, and they may have physical limitations that could interfere with food shopping and meal prep. So many things that we can do now because we have, delivery services or pick it up at the curb, but most places will bring your food right to your door. So if we do find that our patients they have physical limitations, we can help them out by teaching them how to use apps or by getting social services involved. Maybe they need food, Meals on Wheels or something. Sleep. We sleep less when we get older. That is typically true. I can't tell you how many hours, but when we get to the sleep part, I will go over that. That's not today. This is just high-level information. So here's some different things that may affect sleep. We mentioned nocturia. Pain, obviously, would be one that would affect sleep. So if you have arthritis or an injury that's causing pain, a form of dementia, sometimes at night they become very restless. Then you have restless leg syndrome and respiratory problems here. So if you don't get good sleep, all of these things are impacted. So if you don't get a good night's sleep, which is why I say don't study the night before your test, get a good night's sleep, you will experience cognitive decline. And that is very true in our older population. You're at an increased risk for falls, daytime fatigue, reduced physical and mental health, reduced quality of life, and poor ICU outcomes. So consequences of poor sleep. So where was the one? Oh, so it's pretty common, I think, for people that are older to sleep fewer hours at night, but take little cat naps throughout the day. And that's okay, and that's expected. Musculoskeletal system, you have bone remodeling, loss of bone density, loss of muscle strength and size, degeneration of joints and cartilage. So you're going to see that your older population has lost inches in their height. They've lost inches in their girth, in their circumference of their arms and their legs, all because they're losing muscle mass. And they have cartilage and bone deterioration over time. Now we're on to the nervous system, reduced speed and nerve conduction, decreased nerve cells, so you have a small loss of the brain's mass. We'll see that a lot in diagnostics that look at CTs of the brain or MRIs. It'll say age-related brain mass loss or something. Reduced cerebral circulation, increased confusion with physical illness, or loss of environmental cues. So remember what we were saying, if you do not have your glasses, you do not have your hearing aids, you can experience increased confusion if you're not in your familiar environment. So as the nurse, if you have someone come in and they don't have those sensory aids, see if you can get them for them. It makes a massive difference in their outcomes in their stay. What else can I tell you? That's enough about that, I feel like. Sensory. Well, I guess that kind of went along with the last slide. If you can't taste and you can't smell, you're probably not eating as much because you can't enjoy it as much. If you can't hear and you can't see, you are not enjoying your social interactions. You may have more of a risk for falls. You probably shouldn't be driving, but maybe they are driving. So all considerations to keep in mind. Macular degeneration is the leading cause of loss of vision in our older population. And then falls in the older adult. I mentioned this earlier. It's the third leading cause of death for older people. Sad. And then psychosocial aspects of aging. Ageism. So I feel like this is true. as when I was younger, I remember looking at people when I was out and I'd be like, why'd they leave the house looking like that? But now I get it. I'm that age and I leave the house looking like that. And it's because nobody's looking at us. Because why? We're old. I just said that with quotation marks. And it's true. And it's freeing in a way, but in another way, it's not. People look at you and discount you and don't see you at all because of your age. And older people have so much wisdom and so much to contribute, but only if you're willing to listen. And then we have fear of aging. That is so true. I embrace certain aspects of getting older, but I am afraid of losing my independence. And so is everyone else. How many people look forward to the day when they're going to not be able to get out of bed and their kids are going to have to be changing their briefs? You're giving up your independence, and life is changing back to, it's reverting back to almost childhood, where you have to be taken care of like you were when you were a child. Negative images in society. So yes, all of those impact aging. Stress and coping. We already just talked about this. Aging impairs function, activity, and appearance. We can have disabilities from chronic illness or injury. We can have environmental losses related to loss of income. It doesn't say it here, but loss of sensory abilities like hearing and vision, or loss of a loved one. We can't perform previous roles and activities. We have death of significant others, so said that. See what's next. Coping. Really depends on our past experience and how well we did with it in the past. We don't have as many choices a lot of times as we did, or resources to deal with stressful events. Maybe we're on a fixed income because all we have left now is Social Security. So we just don't have a lot of flexibility in how we handle stressful events. And we may have to rely on our families and spiritual beliefs towards the end to take care of us. Here's the living arrangements, which may surprise some of you. 93% of the older population lives in the community. Only 2.3% reside in nursing homes. So interesting, right? And then I left this question in there. Is the following statement true or false? The most common affective or mood disorder of old age is Alzheimer's disease. And again, I'm changing this to say not Alzheimer's disease, but dementia, because Alzheimer's is one of many different forms of dementia. And here's the answer. It is false. Depression is the most common affective or mood disorder in old age. As a matter of fact, you really need to screen your older adults for depression and even suicidal thoughts. There's the different terminology that you should be familiar with in nursing care of the older adult. Here's our number one priorities in managing care for our older adults. So physical safety, cognitive function support, promoting independence in self-care activities, reducing anxiety and agitation, and improving communication. Secondly, providing for socialization and intimacy needs. We're not providing them, just to be clear, but opportunities for socialization. Get them hearing aids if you notice they can't hear. Give them opportunities to get out and socialize with, if it's the long-term care facility, ask them if they'd like to get up into a wheelchair and head down to the hall for bingo, whatever. Promote adequate nutrition. How can we do that? Bring them what they want to eat as close to the diet as, trying to keep them within the diet they're supposed to have ordered. Helping them eat, keeping the smells in their area to unpleasant smells to a minimum. Promoting eating lean protein where necessary. If they have low, if they're malnourished, you want them to get some protein. Promoting balanced activity and rest. So I feel like a lot of your patients, when you get to long-term care, and I keep saying patients because I came from hospital. So every time I say patients, say residents for me. So try to get your residents to get up out of bed and get up and do an activity. I find that a lot of them end up staying in bed for most of the day and they don't want to get up, but it's important for them to get up and get some exercise and some socialization. Then knowing that as people get older, they tend to have more chronic disease processes, which means more medications, which means polypharmacy. So, you go on one medication, which causes a side effect. So the doctor prescribes something for the side effect. And then before you know it, you're taking 15 prescription medications and 10 vitamin supplements. The thing to know is that as you age, your body alters how it processes drugs in all of those ways: absorption, metabolism, distribution, and excretion. So if we're going to be taking care of an older adult, we want to be looking at, are there medications that we can potentially work with the doctors in the pharmacy to take them off of or wean them off of the dose they're on? Or if we need to add another one, we want to start slow or start low and go slow. And make sure your patients know what medications they're taking and why they're taking them. Coordinate all of that with the prescriber. Remember that so often now people have multiple doctors. So you have a cardiologist, a pulmonologist, a nephrologist, and a urologist, and then you have your primary care physician. So that's 5 doctors prescribing medication for you. Sometimes physicians don't want to step on their colleagues' toes by saying, hey, I noticed you prescribed this. Hopefully the pharmacy catches it if it's not something that should be taken with the medication that they're currently taking. But we always want to be looking at, are there things around that we feel they shouldn't be on? What are the factors that are affecting their compliance with taking the medications that they need to take? Is there something we can do to make it easier for them to be in compliance? Is it the cost of the medication? Is it a side effect of the medication? Is it how often they have to take it? What's the reason? And then keep it as simple as possible. And here we go. We talked a little bit about depression being the #1 affective disorder in our older population. Their risk for suicide is increased. And see how it says substance misuse? Don't assume that just because a person is older, they could not be addicted to medications. So they could be. Delirium is also something that they're at risk for. And that is acute, not chronic. So that's the difference between delirium and dementia. So it's a confused state that starts with being disoriented, typically brought on by some type of stressor like an illness. And if they're not immediately evaluated and treated, it can progress to changes in their LOC, or level of consciousness, irreversible brain damage, and sometimes even death. So dementia, the symptoms for that, by contrast to delirium, are slow. So it'll just be like little things, like you'll notice they can't think of words or they can't remember names. And then it'll progress to maybe they walked to the grocery store and then they didn't remember how to get home. So it's starting to progress. They'll repeat the same stories over and over again. That's how it starts. But it happens slowly over time. Alzheimer's disease accounts for 70% of dementia. Okay, I'm not sure if that's what I feel, but maybe it is. Non-Alzheimer's is all those different types. There's actually over 100 types of dementia. So you have degenerative brain disease, vascular dementia, neoplastic, which is due to chemo, demyelinating, so you're losing the fibers around the nerves, infectious, inflammatory, toxic, metabolic, and psychiatric disorders. Alzheimer's says it's the 5th leading cause of death in adults over 65. It affects half of those over 85 and older. And again, I'm going with not delirium, dementia. I really want to substitute that word. It is not a normal aging process. Just know that. And there's two types of Alzheimer's: familial, which is early onset, or sporadic, which is late onset. And then there's all the things about nursing management of Alzheimer's. Most of that has to do with promoting safety and reassurance and providing a calm atmosphere, adequate nutrition, supporting the families. Oh my gosh, it's so hard to take care of people that have dementia, but also supporting independence for the patient as long as you can. And then here's some different geriatric syndromes. I'm just pausing. We've already talked about all of these, I feel like. Increased susceptibility to infection. We didn't really talk about that. Altered pain and febrile responses. We did talk about that in class, where I said, why do you think an older adult female comes into the emergency room with altered mental status? And it's due to a urinary tract infection. And the reason that is because they have altered pain response, because the nerves don't work so much, so they're not feeling the pain from the UTI until it goes septic. And even then, it might not be pain. It's the confusion due to the waste that's filtering throughout their bloodstream. So altered pain response, and then they don't also have typically a high fever when they are ill. They may not have a fever at all. Good enough there. Different examples of elder neglect and abuse. So physical neglect and abuse, psychosocial, emotional, sexual, abandonment, and financial exploitation. I think those are all self-explanatory, but I do want to bring to mind one thing. That is, you could have a family that absolutely loves grandpa, and they're taking care of him and they're feeding him, but he is unable to get up from his recliner, and he sits in that recliner and doesn't want to be moved. And so finally he gets so sick that they end up having to bring him in an ambulance, and it's found that he has stage 4 pressure injuries due to sitting in his own urine and feces. And that family loves him and they're with him and they just adore him. It is still considered physical abuse. So it would have to be something that would be turned into Adult Protective Services. And it doesn't mean that anyone's going to jail, but it does mean that they would potentially intervene and do some education and get some caregiving resources for that family, so that the patient, if they are able to return to their home environment, is not put back in that type of vulnerable place. So I want to point out that it's not always on purpose, but it is our job to recognize signs and symptoms and report it, because it's all reportable and we are obligated to report. And there's some different potential economic effects. It's not, aging's not for wusses, I will say that. I think I'm done. I can't think of anything else I want to add, so bring your questions to class. Thanks and have a great day.